Capnography overview. So capnography is oftentimes used as a kind of a collective term for several different actual aspects of it. So capnometry is the actual measurement of carbon dioxide in exhaled air, and that's a number. So that your normal values there are going to be 35 to 45 millimeters of mercury. Capnography is an actual waveform of those changes in the carbon dioxide that has several different parts that we'll talk about. And then they also use it to refer to colorimetric, which is just basically a litmus paper, and that's what you'll see a lot of times in the field, in the house, when you first intubate somebody or something like that, and that does temporary color change. So that's good for an initial verification, but then you're going to want to follow it up with actual capnography in order to have a definitive evaluation of that airway. So there's two main types of capnography that you will encounter, and they are mainstream and side stream. The biggest thing here is going to be where that sensor is actually located. So in mainstream, the CO2 sensor is located between the tube and the breathing circuit, or between wherever you breathe in, the patient breathes into in the breathing circuit. So advantages here is it's going to provide real-time information, it's more accurate, and there's no sampling tube. Your disadvantages, it's bulkier, it may weigh more, can only be used in your intubated patients, and it's more expensive and requires calibration. Your side stream, which is probably more common, the more common aspect that you'll see pre-hospital, it's lightweight, it's less expensive, you can use it in CPAP patients, non-intubated patients, things like that. It's easy to connect, it's disposable, and you can use it when you're giving oxygen as well. The disadvantages is slightly less accurate, but it's still a good way to measure your end tidal. Now, what we are measuring with this end tidal CO2 is the partial pressure of CO2 in the airway at the end of exhalation. So it directly correlates to the CO2 in the cardiovascular system. So this is why we're actually measuring it here. The good things is breath-to-breath measurement is information almost instantaneously, within seconds. Right? It's not affected by motion artifact, distal circulation, temperature, like pulse ox or things like that can. Now, of course, if the patient's talking, that's going to affect it as well with some artifact, but generally just the actual mechanism of the breathing is not going to create any weird artifact there. We can use this to troubleshoot hypoxemia. We can look for bronchospasms, PEs, all kinds of things. So for your hypocapnia, which is going to be an end tidal of less than 35 millimeters of mercury, some of the major things that we'll be looking for will be like your hyperventilation syndrome. So for whatever reason, they're blowing off more CO2 than they're making, or we could be the ones that are actually hyperventilating them. So this is a good thing to look. It doesn't tell us, though, why they're hyperventilating. It just measures and indicates to us that they are hyperventilating. Another thing would be hypoperfusion. So shock, if blood doesn't get back to the lungs to exchange gas, then the CO2 coming out will be diminished. All right, hypothermia. Once again, CO2 is a normal byproduct of metabolism, and in a hypothermic state, your metabolism slows down, so there's less CO2 to be blown off. For your hypercapnia, you're looking at ventilatory failure. So, the whole purpose of ventilation is to bring in oxygen and get rid of excess CO2 in the body. So, if we are not ventilating properly, then we're going to retain CO2. CO2 retention, in some end-stage COPD patients, they may retain CO2 and they increase slowly and slowly. This can actually kind of turn into that hypoxic drive there because the medulla is kind of numb to all the CO2 signals there, so they rely on the oxygen. So for this, it can tell you if they are still normal stimulus to breathe or if they have gone over to the hypoxic drive. For acidosis, blood pH drops below 7.35, and if we have respiratory acidosis, then there is a high end tidal CO2 and a low pH. And this acidosis, we remember, is going to cause a right-sided shift to that oxyhemoglobin dissociation curve, which is going to mean the oxygen is going to have a difficult time binding to the hemoglobin. This is going to reduce your oxidation to the cells. Wouldn't it be awesome if we could see if this was happening? I think so. So, when you look at the waveform, it's important to note, Bob Page has some awesome information out there about capnography. If you ever are inclined to go look him up, he's got some good books and everything, but he once said that an end-tidal CO2 value without a waveform is like a heart rate without an EKG. In other words, it tells you some information, but it only gives you a little small percentage of the picture. So you need to understand what you're looking at and what each part is in order to be able to actually analyze a proper capnography waveform. So phase one. Phase one is going to be your respiratory baseline. So this is that first flat line there, okay? This is the start of exhalation and is dead space without CO2. So remember, dead space is what got stuck in your bronchi, things like that. All right, as the alveolar CO2 makes its way out of the body, you'll start to see that vertical upstroke in phase two. So phase two is the respiratory upstroke, and what this is the alveoli is releasing CO2, and it's measured when it comes out. For most patients, this should be pretty much vertical. And then it's going to make a 90-degree turn into the expiratory plateau. So that's going to be phase three, the expiratory plateau. And what this is the alveoli are gradually increasing the CO2 until it reaches its peak level. So this is like their smaller alveoli. At that peak level is where it's actually measured, and we get the capnometry measurement, the value. And then phase four is the expiratory downstroke. And it should be almost vertical drop as well, because what happens is when we inhale, CO2 is purged from the airways and the alveoli as pressure is brought in. So this kind of squares off that waveform that you see. Now, before we go any further on steps to interpretation, it's important to note that you will see a difference if you're looking at an on-screen waveform versus a printed waveform. And what happens is, remember the EKG speed is about 25 millimeters per second, and so a normal monitor screen only is going to display about 3 seconds at a time. Well, if the patient's only breathing every 5 seconds, then you're not going to see the waveform on the screen properly. So what they've done is most manufacturers have increased the speed of the CO2 channel to a little bit faster than its normal rate, and this lets you see those waveforms across the screen in real time, but they are not diagnostic. So what you need to do is print it out. In order to properly interpret a waveform, other than just whether it's a square or a flat line, you need to print one out and look at it. So once we've got it printed up and we're looking at it, step one, is there CO2 present? Do you have a waveform? Any waveform at all? All right. Step two, look for rebreathing. So with rebreathing, you get patterns like the one that you can actually see below. Sometimes this is in morbid obesity, late-term pregnancy, some ventilators where exhalation valves aren't opening or things like that. But you see where that baseline is increasing and going up, that's because they are keeping in some of that CO2. Now, step three, respiratory upstroke. Okay, it should be square. Right? Look for any sloping or prolongation like you see at the bottom there. And then step four is going to be looking at the alveolar expiratory plateau. It should be flat. All right, so if that expiratory upstroke is curved, that's going to affect the plateau. This means that we have uneven alveolar emptying, and this occurs usually due to bronchospasm. All right, so this is not just your standard inflammatory response, this is actual bronchospasm. During inflammation, the small airways are narrowed, but they're narrowed evenly. But with bronchoconstriction, they are not even, so you get those differing slopes there. And this causes the capnogram to actually slope towards the plateau instead of forming a square waveform. And then five, finally, read the CO2. So the end-tidal value, look and see what it is. Our normal range, 35 to 45. So if you have a normal CO2 value and a square waveform, it indicates that there's no obstruction in CO2 emptying, the adequate breathing, and their perfusion is adequate because you can't get a normal or high CO2 reading while hypoperfusing. So the ABCs essentially are intact. Now there are quite a few clinical applications. As far as intubated patients, we can use this to confirm tube placement. It is pretty much the gold standard for endotracheal tube confirmation. We can use it to assess for adequate ventilation after intubation. We also can get some early warning time for intubated patients that are waking up, such as here, which is called a Curare cleft. And this little indentation means you've got a couple minutes and then that patient's about to start fighting you if you don't sedate them or pull your tube if necessary. Right? Now, for your non-intubated patients, we can use this to look and see if they have asthma, if the problem is a bronchoconstriction problem versus an inflammatory problem in there. We can also use it to help differentiate between your COPD patients if they have a rebreathing problem or a bronchoconstriction problem with the COPD, or if we have a CHF with pulmonary edema issue, if there's any bronchospasm or not. Some other things you may see, right main stem bronchi, intubation. All right, the initial peak is going to be due to that carbon dioxide from the well-ventilated lung, and the second one's usually going to be the prolonged expiratory time of the poorly ventilated left lung. Some other changes, esophageal intubation. You may get a little CO2 spike initially from gastric CO2, from like mask ventilation or something like that, but it will taper off and will not be any substantial waveform or noticeable patterns there. And if you get some funkiness that starts happening after your initial waveforms, you may have an air leak due to a broken connection, some more like that. Right? Pediatrics. Pediatrics are a whole other ballgame. These capnograms can occur in children and neonates. Your variations are fairly normal, and they occur faster due to faster respiratory rates, smaller tidal volumes, and a longer response time of the capnograms. Carbonated beverages can also create some abnormal capnograms, but the main thing that you will see is that they are continually decreasing as they go, so that you know it's not an adequate intubation.